repairing, what are the patterns, and you can see you can look at the evidence of the incidence of what's happening in the world. The rates of cuff repairs are increasing. What are the goals of repair? Restoring anatomy and restoring biomechanics, strong fixation. So release the adhesions, mobilize the cuff, oppose the cuff onto the footprint, and anchor the cuff onto the bone so it heals well. That is to improve shoulder function. Ideal cuff repair, high initial fixation strength so that you can hold the tendon onto bone and it heals well, withstand cyclical loading, greater contact pressure on the bone tendon interface, and greater contact area too, not just the pressure, it's also the area of contact of the tendon on the bone. So you need to know the anatomy. What is the anatomy? It's a very wide attachment, about 1 centimeter. And studies have shown supraspinatus is about 7 millimeters and infraspinatus about 1 centimeter. So nearly 1.5 centimeters of that footprint needs to be covered. What are the weak links in a cuff repair? These are the weak links. So suture tendon interface, not bone anchor interface. We always talk about the bone anchor interface. We don't talk much about the suture tendon interface. So suture tendon interface, very important to use thin devices so that you don't make a bigger hole on the tendon, so that there is no compromise of the suture tendon interface. So use thinner devices to pass your sutures. Fixation of tendon onto bone, you have either a transosseous, which was the gold standard of repairing rotator cuff, like the mini open and the open repairs, and now we are able to do that arthroscopically with devices like these. But anchors have been easier to use, and suture is held in the anchor onto the bone, and they are definitely design dependent, and angle of insertion is important, and the configuration of how you put them also is important, but it's expensive. If you look at the outcomes of these transosseous suture repairs and suture bridge techniques, the results are same. So arthroscopic repairs with anchors is equivalent to a transosseous suture repair we did open. That's MRI proven. Configuration of tears, you can either have a single row repair, which is where you have one row of anchors and the tendon is repaired onto the footprint. But these suture anchors should not be put on the medial side of the footprint, but on the lateral side of the footprint, so there is more opposition of the tendon onto the bare footprint. So that's a single row configuration. A double row is where you have a medial row and a lateral row, but there is no tension in the whole repair. So the transosseous equivalent is like the transosseous, we'll have a tension or a suture bridge, which is actually plastering the tendon down onto the footprint. So you're increasing the chance of healing, but could compromise the vascularity of that part of the tendon. So single row variants, again, single row can be of that configuration, or you can have a tension single row where you have the mattress sutures to the tendon and put a lateral row anchor. So it actually anchors and plasters the whole of the tendon onto the footprint. So this anchor device, which is known to have a compression attitude, where as you tension the anchor, you can see the suture will get tighter and it will plaster the tendon edge onto the footprint, like so. Double rows, medial row and a lateral row, very useful for the laminated tears. I think Ram will be talking about that. I won't touch upon that. But it's not plastered onto the footprint, so there is no pressure. So looking at biomechanical studies, double row repair is much stronger than a single row repair, and is ultimate load to failure is similar to an intact rotator cuff. Systematic review of about 9 studies showed that the biomechanical strength, load to failure and gap formation is better for a double row. Footprint restoration, where I mean that the whole of the tendon is put onto the whole of the footprint, it is better with a double row than with a single row. The variants of the double row is the transosseous suture bridge, where you are actually plastering the tendon down, where you are having 2 medial row anchors and 2 lateral row anchors, and the sutures are crossed over the tendon, so it is plastered onto the footprint again. So Park had described this very well, and he also went on to do a pressure analysis of how much of pressure is there between the tendon and the footprint, putting a force plate between the two structures, and he found that it is better with a double row, the transosseous equivalent with a double row. Whereas the middle one is like a parachute technique. I use that often because of cost constraints with our patients, and I don't use the 4-anchor technique much. Gap formation is less, so these patients can go on to cyclical loading or mobilizing early. Other biomechanical studies also showed that after healing, also a double row is better than a single row. Now, identifying the type of shape of the tear is important because mobilizing this tendon onto the footprint is important. If the outer leaves are intact and the inner leaves are reasonably intact, you can either go for a single double row like this, where is in the medial edge and on the lateral edge, and close the V, or you can go with opposing the tendon there, reducing the size of the tear, and reducing your anchor usage also, and using only one single row anchor as well. Cuff reducibility is important. I always check for cuff reducibility from the articular side and from the bursal side, so that you know that the whole of the cuff is plastered down onto the footprint before you actually tie your knots. Suture bridge double row technique, where you have a cuff tear like this, you have to clear the footprint, so there is bleeding bone, and there is some controversy about how much of it you need to do, but I always get enough bleeding bone before I anchor the tendon down. The lateral row will actually plaster that tendon down. That's the articular sided view of post repair. Now, if you look at the non-tension threads to a tension thread, you can see how much of the tendon actually mobilizes and how much it is compressed onto the footprint. And the articular sided view shows you how well that tendon is restored onto the footprint. Now, there are various variations. You have 3-in-1 hybrid suture technique like this, where they have used 2 medial rows and a triple loaded anchor, and then put all the sutures down so that you have better compression. But I worry about the vascularity of the tendon when you have such sort of a configuration. There are also variations of a tripod technique, where you put another anchor to relieve pressure on the lateral row anchor, which I don't recommend because there are too many anchors there. But you also have another technique like this, where you have a simple suture, a mattress suture, in addition to your medial row anchor sutures. So where you're using the mattress suture as a traction suture and offloading your anchors. So this, if it is a mobile tendon, you see it's laminated, you get the medial edge to the medial edge of the articular surface. And there are only 2 sutures in this anchor. You see the blue and white and the white one. The blue and white will go back, and that black and white is the mattress suture. So that helps in offloading your anchor itself. You tie the ones which go through the anchor, and you don't tie the ones which is mattress suture, and use all the 3 limbs to go laterally. So you get a good compression of the tendon by using lesser number of anchors. Knotting of your medial row anchors, knotted versus knotless, there is no difference in outcome. So you can prefer to do a non-knotted medial row anchor, but I prefer to do at least a couple of these sutures to be knotted and some of them non-knotted, depending on the configuration of the true. What is the evidence for clinical evidence for single row, double row? Systematic review 2014. 7 eligible randomized controlled trials, no significant difference in the constant score, but they found that the external rotation shoulder strength index, the tendon healing, was much better in a double row technique than with a single row technique. Statistically significant advantage of the double row in patients who have a size of tear which is more than 3 centimeters. Recent one from UK, again, meta-analysis showed no difference in outcome on the meta-analysis. MRI healing rates, if you look at it, the transosseous equivalent has about 90% healing rate, whereas the single row has only 70% healing rate. If you look at the Guttler stage and the healing, then the greater the gluteal stage, lesser the healing. So quality of the muscle and tendon unit is also as important as the configuration of the repair itself. So this I put on to know that when you actually start your actual rehab, the intensive rehab, better do it after 15 weeks because the strength of the tendon is better at that point of time. So configuration of suture anchors depend on the type of the tear. Small and medium tears heal well with either of the constructs. Larger tear, go for a footprint restoration type of repair and use a thin caliber suture passer. Thank you.